Hello, my name is Elliot Paz. I'm a teaching assistant at Montana State University Northern. And for today's lecture, we'll be going over Chapter 6, Non-Communicable Diseases, out of the book Public Health 101, Improving Community Health by Richard Riegelman and Brenda Kirkwood. And our objectives for today's lecture is describing the burden of non-communicable diseases on mortality and morbidity in the United States, describe the ideal criteria for a screening program, explaining why 2 or more tests are nearly always required to screen for an asymptomatic disease, explain the multiple risk factor intervention approach to control a non-communicable disease. We're also going to be describing the meanings of cost effectiveness, describing several ways that genetic interventions can affect the burdens of non-communicable diseases, and describing ways that public health interventions can be combined with clinical interventions to more effectively reduce the burden of non-communicable diseases. All right, so now to start off our lecture, what is the burden of non-communicable disease? Well, when we're talking about non-communicable diseases, we're talking a wide range of major diseases, though infections may play a role. We have cardiovascular disease and cancers, which those alone account for 50% of deaths in the United States. We also have Alzheimer's and depression and arthritis. However, while deaths are a significant part of the burden, NCDs also have a profound effect on the quality of life. Chronic disabilities, mostly caused by NCDs, are the fastest growing component of morbidity, which means that there is an increasing number of people living with these long-term conditions. And as populations age, NCDs will only increase in frequency. More people living longer means a larger senior population and more chronic conditions and disabilities. And this growing burden puts extra pressure on the economy, not just through healthcare costs, but also in terms of workforce participation and quality of life for those who want to continue to work. Now we also have the opioid overdose crisis. Unfortunately, the rise in opioid overdoses have been particularly severe in the US, increasing from 20,000 deaths in 2000 to over 100,000 by 2020. And this crisis is disproportionately affecting teens and young adults, which has a significant impact on life expectancy. Mental health conditions are major reasons for disability and morbidity, but also it hasn't always been treated as a major health issue. Only recently have we seen a shift in awareness. Now, curative, and rehabilitative approaches are now available, but public health strategies remain limited. Some of the key approaches include screening for early detection and treatment. Catching diseases early leads to better outcomes. Multiple risk factor interventions, which is addressing multiple factors at once, is more effective. Cost-effective strategies, finding affordable ways to tackle these diseases. Genetic counseling and interventions, helping people understand and manage their genetic risk factors. Combining clinical and public health interventions, collaboration improves overall effectiveness. And ongoing research, continual advancements in understanding and treatment. And these approaches are what we'll be focusing on for the majority of this PowerPoint. All right, so now screening for disease address the burden of non-communicable diseases. Well, first off, what is screening? Screening for disease involves testing asymptomatic individuals, meaning people who do not show symptoms of disease. However, just because someone appears asymptomatic doesn't mean they are truly symptom-free. There could be underlying issues that have not been manifested yet. And this makes the early detection crucial for improving health outcomes. Now, some examples of a successful screening can be with, say, colon cancer, hypertension, and vision and hearing issues, especially with childhood conditions. And these conditions are often more effectively managed when detected early. And successful screening programs can lead to reduced disability and decreased death rates due to early detection and treatment diseases. Now, what we got here, what we call our 4 criteria for a screening program. Now, one thing to know is that not all communicable diseases are ideal candidates for screening. And in some cases, screening programs haven't been developed yet. Now, there should be 4 criteria that need to be met for an ideal screening program. However, there are a few screening programs that will actually completely meet all 4 of these criteria. But these provide a good standard for evaluating potential screening programs. Starting off, the first one is substantial death or disability. And this is probably easiest to evaluate. Does the disease cause serious enough damage for death or disability? So an example, breast cancer is the second most common cause of death in women under 70, And then further along, colon cancer is the one of the most leading causes of cancer-related deaths in both men and women. And also, while childhood hearing loss and visual impairments may not always be obvious, they are quite common and can cause significant disability. So those can be examples. Now, our second one is, does early detection improve outcome? Now, to start off, this is more difficult to assess because early detection only matters if it leads to improved treatment or outcomes. So an example of this could be, say, screening for lung cancer in smokers might sound good because it's the leading cancer killer of both males and females, but the issue is that X-ray screening often doesn't detect lung cancer until it's too late for effective treatment. And this is what we lead to called lead time bias, where early detection doesn't actually improve the outcome. Now, a third one is there a feasible testing strategy? Since screening often requires identifying high-risk populations, like men at the age of 45 for colon cancer, or women at age 50 for breast cancer, it may also involve using multiple tests to distinguish between false positives, people who don't have the disease but they test positive, and then false negatives, people who have the disease but test negative. And this is often done using a simple initial test, like a blood test or a physical exam, followed by a gold standard test, such as a colonoscopy or biopsy, and which this strategy is called sequential testing or consecutive testing. Now, our fourth criteria is acceptability, where screening is acceptable in terms of harms, ideally lack thereof, costs, and patient acceptance. So starting off for harms, if we're talking about physical examinations, blood tests, and urine tests, these are often used for initial screenings and are relatively harmless. But one needs to be done if the initial test is positive. Further invasive tests might be required, such as surgeries or biopsies, which come with risks. Then, following up on costs, screening frequently can be very expensive. So we need to determine if we should do them every year versus every 5 to 10 years. Example, this could be screening every year for breast cancer, which is more costly than screening every 5 to 10 years for colon cancer. And the frequency of testing depends on the disease and how it progresses, as well as the expected false negatives. An example of this here is that breast cancer can develop and spread rapidly, so it's recommended to undergo screening every year, whereas colon cancer moves much slower, so longer periods between tests are more acceptable. Then for patient acceptance, of course the acceptance of screening also matters. Some tests like colonoscopy are very invasive and uncomfortable, but the development of a DNA stool screening is much less invasive and more acceptable. Alright, so what I have here is table 6.1, which illustrates the common screening tests for cardiovascular disease and common cancers based on the 4 ideal criteria which we just discussed. And the criteria also guides us in determining what tests not to run, such as if an early detection does not improve outcome, like with the X-ray smoker example, there's no point in screening for that disease. Or for rare diseases where tests may be less reliable and not effective, and if follow-up tests after initial screening are potentially severely harmful, then the screening should not be performed. Keep those in mind. All right, so now we'll be going over some examples of a screening test, maybe for heart disease or cancer. Starting off with which we're going to be talking about breast cancer. It's the second most common fatal cancer among women and most common for women younger than 50 years. We do say that early detection improves outcome. Now for women 40 and older, a combination of a mammogram and a follow-up biopsy is shown to be a feasible screening method. Now harm still may occur due to a false positive. There is still a low risk of harm from the radiation, but the test also is somewhat painful. Then for cervical cancer, we see that if it's undetected and untreated, it may be fatal. We see that early treatment does drastically reduce the risk of death, and pap smears and follow-up testing have been extremely successful. Now, pap smear results in a substantial number of false positives, but new DNA testing may be used to separate true and false positives. So here, it fulfills the 3 requirements we talked about in the last slide. First up, are these diseases rare? No, they're not. Now, does testing improve outcome? Yes, it does. And do these tests cause severe harm? According to this, they do not. So we're good there. All right, so now here is just another example of the screening tests. So for this example, it's going to be focusing on colon cancer. It's the second most common fatal cancer in men and third in women. So we all see that early detection of polyps reduces development of cancer. and early detection improving survival, so it fills that method, and it's also very common. And the screenings can be done via stool DNA testing or blood testing, a flexible sigmoidoscopy, colonoscopy, and virtual colonoscopy. Now for patient acceptance, we see that with the colonoscopy and the virtual colonoscopy, they both have a high cost, but thankfully still only a small probability of harm, though granted those two are very invasive. However, with the stool DNA testing, that essentially eliminates the invasive factor that comes with the colonoscopy. So overall for the screening, we see that A, they do improve health outcomes. At least we have some options too, so they're not as invasive, and they don't cause much harm, if any at all. So that's how, in this case, the screening for colon cancer fulfills these requirements.